Welcome to the Limitless Leaders podcast series brought to you by ASPS, the Aesthetic Society, and the American Hernia Society with the generous support of Allergan Aesthetics. My name is Dr. Ashley Amalfi, and I'm a board-certified plastic surgeon at the Quatella Center for Plastic Surgery in Rochester, New York, and I'm the chair of the ASPS Women Plastic Surgeons Forum and the Limitless Leaders Steering Committee member. Please join us for Season 2 of the Limitless Leaders podcast, where we dive into the stories of extraordinary women making a significant impact in our field, as well as the men who are supporting them to get there. We are breaking gender barriers and inspiring the next generation of leaders.
Good evening. You're listening to the Limitless Leaders podcast series brought to you by ASPS, the Aesthetic Society, and the American Hernia Society with the generous support of Allergan Aesthetics. I'm Dr. Nupur Gangopadhyay, today's special guest host of the Limitless Leaders. I'm a pediatric plastic surgeon in Chicago at Lurie Children's Hospital. I've been in practice for about 7 to 8 years. I've had the great pleasure of working with Dr. Bajaj on Limitless for the last 3 years. And I'm really excited about today's podcast. So tonight, we have Dr. Anu Bajaj, as well as Dr. Victoria Vastine, to discuss implicit bias. Welcome to you both.
Thank you, Nupur.
Anu, I'm going to let you introduce yourself first, and then Victoria, I'll have you go after Anu, and then we'll dive right in.
Okay. Thanks for the introduction. So everyone, I am Dr. Anu Bajaj. I'm in private practice in Oklahoma City, and I've been in private practice since 2007. My practice has evolved from a primarily reconstructive practice, and starting in 2007, I did mainly DIEP flaps, and for many years, I was one of the few, if not the only surgeon in Oklahoma who did free flap breast reconstruction. And over the past 5 years, I've evolved into a primary aesthetic practice. I've been involved with both the American Society of Plastic Surgeons, or ASPS, and the Aesthetic Society for a number of years in various leadership positions, including chairman of the women's committees of both organizations, involvement with Limitless, the Ethics Committee, and Plastic Surgery News. I still maintain most of my involvement, but I've tamed it down a little bit, and I'm also an oral board examiner for the American Board of Plastic Surgery.
Excellent. Thanks, Anu. Victoria, what about you?
Well, I'm Victoria Vastine, and I am in practice in Charlottesville, Virginia at a community hospital. For 15 years, I was in solo private practice, and then I made the decision to become employed by the community hospital that I was already working in. And I have been in practice for 25 years doing a mix of sort of community-based reconstructive procedures and cosmetic procedures. And I, too, have kind of drifted a little bit more towards cosmetic. I think it's a normal thing in those practices that do both. I've been involved in local leadership, state leadership, as well as ASPS. I'm a member of the Aesthetic Society as well, but haven't really done much leadership with them. I am a past chair of the Women's Committee, as well as involved in advocacy as the chair of the subcommittee for state legislative advocacy. And I'm a past president of the Virginia Society of Plastic Surgery as well.
Thanks, Victoria. So I think this is a really important topic. So, implicit bias or unconscious bias is something that we are talking about more in the last 10 years. And I think certainly as all female plastic surgeons on this call, we all have experienced it in some form or another, whether that is in our training or even, unfortunately, still in our day-to-day. So if I could get you all to each start with maybe an example of how you have sort of experienced implicit bias directed towards you and how you handled it, or if you sort of see it in your own practice or on a leadership level, and what you kind of, what advice you give to others now that you've been through it.
I can tell you how I've experienced it. I'm not sure that I still have a full handle on how to manage it.
Mm-hmm.
if I'm to be honest. I will tell you, as recently as the past week and a half, I was in a committee meeting, and we know that titles and names matter. And we had a significant number of medical students at this committee meeting. And my co-chair of the committee meeting referred to other physicians, male and female, who were also at the meeting by the title doctor, but referred to me by my first name. And I do believe that titles matter. And if we're going to refer to everybody by doctor, we refer to everybody by their title. Otherwise, we refer to everyone by their first name. Food for thought. I didn't know how to respond. It upset me. And I think these types of biases have been present for a long time. Another story I told was as a resident, when I was conference resident at my institution where I was doing residency, and this was in the 90s. The conference resident would organize conferences, but I have a letter of reprimand from my program director that still sits in my filing cabinet in my home as a memory and a reminder, that reprimanded me for failing to throw away the paper plates and push back the chairs to the conference table at the conclusion of conference, something that none of the male residents were ever responsible for. So I think those are examples of implicit bias. I think the thing that I struggle with is, even in the span of 30 years, I'm not quite sure how to respond to these instances.
Yeah, I totally understand what you're saying. I have sort of a similar experience with, my male colleagues being called doctor, last name so-and-so, and, I am either Nupur, which is my first name, or Dr. Nupur. They just refuse to say my last name. And it's frustrating, and especially when you're not being treated equally. Victoria, what about you? What have you sort of seen in your experience and in your workplace?
Well, definitely in my personal experience, implicit bias has been around for a very long time, much longer than the 10 years that it's become a hot topic. I recall an interesting story from when I was a child, and that is I'm a child of Title IX. So as Title IX was passed, I was a young athletic kid who wanted to play baseball, and it became a requirement that they allow you to do that in Austin, Texas, where I grew up. And my mother, who was very progressive and very supportive, encouraged me to play if that's what I wanted to do. Where the implicit bias comes in, it was overt bias everywhere. But after a year of playing and proving myself, I started puberty. And my mom said I could not play baseball because I was developing breasts and might develop breast cancer if I got hit. She was basically feeding back what pundits and news reporters had said when interviewing why women shouldn't be allowed to play baseball. So from a very early age, I saw that your beliefs and perspectives could be impacted by the people around you. And she became worried when I was about to become a woman that this was going to impact my future ability to have kids and breastfeed and do stuff like that. On a more adult level, obviously, we've all experienced the situation where, as Anu said, you're addressed or viewed a little bit different. I think I was lucky in that my medical school and my residency training for general surgery, I did not have that issue. But I will say that one of the plastic surgeons that I really looked up to and thought was quite wonderful, many years down the road, published a paper about social problems in residency. And this involved reasons residents miss training, including drinking and drug problems, anger problems, debt, gambling, and pregnancy. And at the time, I was the chair of the women's committee, and needless to say, I got a very vocal outpouring from women plastic surgeons about how are we going to respond to this. And we responded with a letter to the editor that was dramatically toned down before it was agreed to be published. And ultimately, there was a panel discussion about this topic. And one of the authors stood up and was really feeling attacked and blindsided. And I think that's when it became aware to me that because it is implicit bias, they really don't view themselves as being biased. And, one of the comments I made during that panel discussion was, we understand it's an implicit unconscious bias, but that's why we're pointing it out. And I think that is not always super easy, but it is something that I've tried to do in response to implicit bias, is to pull that person aside or to make a point of, at the conference table when I'm in charge of the meeting, to then emphatically state, so Dr. Bajaj, what is your thought on this? Or to acknowledge when people are kind of getting that little microaggression slight. I try not to do it as much in public, although sometimes that's really what it does take for them to just really stop and look at what they're doing.
Victoria, I think that's such an important point that you raised about this kind of association with implicit bias and microaggressions. I think we've all probably faced some form of microaggression, either in the recent past or in the distant past. I'd be interested to know both of your thoughts on, how you feel like implicit bias relates to microaggressions, and why maybe women in a surgical field seem to experience this more than, say, a male physician would in a surgical field.
Well, I'm happy to comment first on that. I personally feel like the microaggressions are just sort of the bubbling up of the bias. They just can't hold it in.
Mm-hmm.
And, another example was at a national meeting in the leadership arena where the president of the society sits down to have a chat with everybody, and he turns to me and he said, so tell me a little bit about yourself. I mean, this is a big deal to be here. And I started with saying, I have 4 children and I'm in private practice and blah, blah. He goes, well, why aren't you home with your kids? And it was just, it's like his mind couldn't prevent him from blurting it out.
Wow.
And I said, well, who's home with your kids? I said, my spouse is home with my children, and that's, it got his attention. He realized what he had just said. And so I think a lot of times the microaggressions are just as unconscious as the bias, and it just pops out.
It's interesting. I remember when I was in the general surgery portion of my training, our chief resident, who was a female, was making up the call schedule. And it was for the holiday call schedule in December. And one of the junior residents, he literally said to her, well, I can't be on call Christmas Eve because I've got a family. And her response to him was point blank, well, I can't be on call Christmas Eve because I have to meet a man so I can have a family. Which, I mean, it's a little bit of the reverse, but that's truly an aggression, like saying because you're a single woman, you have no life, and because I'm a man with a family, I'm more important than you. It was just interesting. I loved it. That's something I'll never forget.
No, and I mean, how incredible to be able to be that quick-witted in the moment to speak up. I think one of the things that I think both of you have done very well on a national level, and certainly in your day-to-day, is I think you're aware of the importance of implicit bias, maybe because you've experienced it yourself, or because you're not afraid to call people out. And so I wondered if either one of you had done additional training, like with the implicit association tests, or was it just something that both of you came to the realization that, like, we need to be aware of this, and I'm going to become educated on it? Because I think I certainly know on a national level that when I think about both of you from a leadership standpoint, I do feel like people get a fair share in the room, and that we are hearing, the truth and as unbiased as you possibly can be for the members in the room.
Well, Anu and I have both been through the leadership training, which, while it doesn't specifically address implicit bias, the Pathways to Leadership program focused heavily on listening. And I think that's a very important part of, one, recognizing your own biases, and two, getting a little bit to the base of other people's biases. I haven't done any specific training other than what my kids teach me at the dinner table on a constant basis about listening to other people and getting their perspective. I don't know about you, Anu.
No, I completely agree. I have not done any formal training. It's something I've become more aware of through the different leadership venues that we've had, whether it's Pathways or EOL. And I agree that learning how to listen to others is a huge skill that many people in leadership do not practice because they like to hear themselves talk rather than listen to those around them. I don't know if you guys remember, but Jocelyn Vaught, who did some of our leadership training for Essentials of Leadership, she used to call it the wait principle, whereas before you speak, you say, why am I talking? So you shouldn't be speaking unless you have something very specific to say, but the rest of the time we should be participating through active listening. And that's how we learn about others. And frankly, that's actually what we should be doing in our medical practices, because that's how we learn about patients and what their goals and their desires and their needs are. And that makes us better doctors, in addition to better leaders in the long run.
I love that. Obviously, I think there's a statistic that doctors in general during a patient consultation will jump in after an open-ended question in about 20 seconds, which certainly doesn't always give our patients time to express themselves. But certainly being a better listener can also allow you to have the perspective of where the person you're talking to is coming from. So that's, I think, one great strategy. How would you say as individuals, you all try to reduce implicit bias in your lives?
I'm learning how to, in a non-combative or non-confrontational way, talk to people about it. And that's a day-to-day existence. For example, when people don't refer to you by Dr. Bajaj, rather than allowing it to slide, you have to point it out. Because in certain circumstances, I am Dr. Bajaj. When I'm talking to both of you and we're sharing a glass of wine at happy hour, that's a different arena than when we are dealing with patients, nurses, and professionals.
Absolutely.
I agree that a lot of what I do, trying to kind of delve into the biases that you see in the hospital, see in the office and stuff like that, is I tend to be the one that people come to talk to me about their concerns. So unfortunately, I seem to have become the office mother, but they will come to me and say, I'm just so upset because this happened, and what am I going to do about it? And so that opens my eyes as to how these things sort of transmit through the practice. But two, it gives me an opportunity to say, well, I can go and talk to this person, but that's not really going to solve your problem. You need to be able to go to this person and say, well, I find it, honestly quite offensive when you forget to address me by my title, or you talk to me like I don't have the same rights as the other providers in this practice. And, I had a junior partner who's not in our practice anymore, but she came to me saying, I'm so frustrated. Everybody calls me B, her first name, but nobody calls me doctor, and everybody calls you doctor. And I said, well, one, they're probably a little bit afraid of me, but two, the first time they do it, you have to say, I'm sorry, but you really need to address me as doctor in front of the patients. And then that gets them thinking about the fact that they never address you by doctor. Um, so it's that sort of thing. I've learned a lot by watching other people struggle.
Mhm.
um,
One of the things I think that's important for us going forward is obviously implicit bias can kind of affect us on a personal level, but then I think it can also affect, our patients as they try to access like healthcare systems. And this is maybe a challenging question, but I'd be interested to know what both of your thoughts are on ways as systems, like as hospital systems, healthcare systems, we can decrease like sort of institutional bias and systemic bias, which I think are just sort of a bigger, picture related to having implicit bias.
I think it's really hard to say you're going to aim for the system without first taking it one step at a time and gradually working through the system. I think that just with the whole process of women in medicine, women in surgery, women in plastic surgery, diversity beyond gender in plastic surgery, we have slowly turned the tide and therefore will ultimately affect the entire system. An example, of starting small and working up is I noticed early in my practice that there were certain cultural groups that came in hot when we were talking about breast cancer or even medically indicated but relatively elective surgery, and they were aggressive up front to the point that I was like, oh my God, this is really driving me crazy. Why is it always this particular culture that does this? And then I really started thinking about it and realized they're so used to not being heard and to being overlooked that when it's their life on the line and it's important to them, they come in hot. And then from that, I had another colleague saying, I just find it really hard to deal with this. And I said, well, look, if you stop and think about it, this is why they're coming in hot. They were like, oh, that makes a lot of sense. And then that trickled into cancer clinic, where they're like, these are really difficult people to deal with. But when you actually pointed out that they're in a crisis in their lives, they feel like they're never listened to, and everybody sort of stopped and said, oh, well, maybe if I just spend a few more minutes listening to what their concerns are, it'll get better. And I think it made a real shift as to how it was truly a cultural bias that was causing these patients to not be adequately cared for. And, the flip side of that is we also had legislation starting because minorities were not being treated equally. They were not being given the same education regarding Reconstruction. All these things that kind of trickled up started from somebody taking the time to notice that the reason this person was so obnoxious on first meeting was just out of the will to be heard.
I think that's true for all of our patients. They do just want to be heard, and we don't do that. And then furthermore, we don't make people, or we don't welcome them and allow them to feel comfortable. I mean, within our own journals, websites, whatever, for years we've had so much implicit bias because we've portrayed this typical plastic surgery or reconstructive patient in a certain way. And we haven't acknowledged that when you differ from that ideal picture, we embrace you, and we haven't until now. I think that's where things have started to change. Think about it. I had a patient 3 or 4 years ago who came to me for an abdominoplasty, and she said to me that the only reason she came to me was because I was the only plastic surgeon whose website she reviewed, who had before and afters on my website of people with different ethnic backgrounds. And I think that's important to understand, that as plastic surgeons for years, we haven't acknowledged our own biases in that. And that one way to change that is to change those basic things that, our models, our before and afters, they're all diverse, just like the rest of the world is.
It's very interesting how you all have individually tackled this. And I think to your point, Victoria, you're right. Like the system doesn't always fix the problem. So, the National Institute of Health has listed implicit bias as one of the most significant socio-cultural factors that affects like healthcare. And so they kind of have divided it into two things, like what are the usual diversity programs that people do? And there's, of course, mandatory diversity training. There are like job tests, which is interesting because they will often test females and minorities. And it's not that females and minorities perform poorly. That's just that white men sometimes get a pass on having these job tests. And then the other thing is sort of these like grievance systems, which are not quite anonymous, but are supposed to be a way for people that are dealing with implicit bias and microaggressions against them to feel comfortable reporting. And unfortunately, all of the data from the National Institute of Health that they've collated has shown that none of these work well. In fact, most of them work, less than 5% of the time. And in several situations, they actually turn women and minorities away from certain job environments. Some of the things that the National Institute of Health said might be better and has like maybe a small favorable effect are things like self-managed teams, cross-training, mentorship, and then honestly, like a diversity task force. And I'm interested to hear your thoughts on some of the things that do actually have work, because one of the concerns I always have is when you have something like, kind of mentoring and diversity task forces and like kind of self-management and voluntary training does this put an undue burden on people that are sort of already aware that implicit bias is a challenge, or maybe people who are already in an underrepresented group having to do more of the work? Like, this is a tax we're asking them to pay in addition to dealing with the implicit bias and microaggressions.
I think historically it has been a tax. I know personally from my leadership in my hospital, they would often ask me to, quote, sit down and have a chat with another woman surgeon because they were having behavioral problems. And I would say, I'm more than happy to do that, but first I'm going to look into all of it and, look at it from a peer review perspective, not just you want me to slap this person on the hand. And 9 times out of 10, it was not a behavioral problem, it was a perception problem. And the woman surgeon was viewed as being loud, being aggressive, being rude, demanding, all these things. And when you sat down and really talked to whoever had filed that complaint, and you would say, well, if this had been Dr. Mister, has he ever done that? And they were like, well, of course he has. All surgeons do that. But it's not acceptable when a woman does it. And then I would go back to leadership and say, this is a perception problem, and you need to back up these women surgeons and have them be under the microscope less, and have the guys that throw the instruments across the room under the microscope more. And, I think that's traditionally how things have gotten done, is they choose someone who represents the minority to handle the tough work and try to fix what they perceive as the problem, when the problem is actually quite often the opposite. But I do think that leads itself to say, the more diversity you have in leadership, the more diversity you have in your institution, the more likely you are to break through some of these biases because there's more perspectives and more explanations and more listening and more careful conversations.
I think you make a very good point, Victoria, because it's true. A lot of the complaints or issues that we have experienced have been related to implicit bias. And the only way to get beyond that is to have more diversity of thought, which is key, right? Because then you have different stories and different or broader stories than the stories we've always heard over the past many, many years. So I think what you said is very, very true.
I know my personal implicit biases often revolve around differences between how I was trained or what my personal life expectations were, et cetera, and how different it is with, quote, the younger generation. And just the way I say that shows my biases in that there, diversity includes age. And I think it's great that the societies have really tried to tap in more to the residents and even to the medical students in terms of serving on committees and stuff, because I really do think that they're helping to shape their future, but they're also educating everyone else. Plus, that gets them at the table seeing, quote, the real world, the real problems, the real issues that need to be dealt with. And I think that's important as well.
I love that, Victoria. I think that's just it's a good point. We sort of joke a little bit about it, right? Like there's obviously this kind of generational bias, even the same thing of like, I remember being a resident who's my first 2 years, we didn't have the 80-hour work week. And then later on, obviously we switched to the 80-hour work week. And then, my residents currently sort of not having the same perspective of what it was like before then. And so, it's not, I think to your point though, you are actually aware of what some of your biases are. And I think it ends up being an individual task to hopefully make yourself aware and then do what you can to combat those. I would be interested to get your thoughts on if either one of you have been in the situation of as a woman, either in an area that you were an expert in or an area that you were sort of leading the charge, if you had been told to either like check your facts or kind of sit down and, let the men in the room talk. Because I was actually surprised when I went to a meeting of other female surgeons, just of various specialties, that they'd all sort of recounted that. And that was not it wasn't age related. It was, people that are just fresh out of training to people that had like been in leadership for like 10 or 15 years.
I would say yes, I have experienced that. And at first I would internalize it. And now I have become philosophical and say, okay, I will let others, maybe it's more important for me to hear what others have to say and allow them to proceed. But the example I would give is that there have been numerous times with my involvement at different leadership levels where I've been asked to pick and choose and allow someone else to take a leadership role to allow someone else to advance.
To be honest, for me, I think I have such bad imposter syndrome that even when I know I'm more than qualified to do some things, the moment I see resistance, it reinforces my belief that I really don't have that skill set. And there have been times in committees where I'm chairing it. I'm the one leading the charge, so to speak, and someone will talk right over me and say something along the lines of, "It's pretty clear that you don't know what you're talking about," and I will quote on this one. Just because you're reading from the card in front of you doesn't make you an expert. When it's written in front of me, because I get so anxious, I don't want to miss a point, that I have it all in front of me. And in those situations, I will say the majority of the time at a national level, I just kind of shut up and sit back in my chair and, try valiantly to regain control of that committee. On a local level, I think I've been so involved in the leadership of the hospital, starting as the chief of general surgery, then the chief of plastics when we had plenty of plastics, and now peer review chair, med exec, and all those things. I feel like I'm in the point of my career where it's my job to not shut up. And I will continue to say things long after the chair has tried to say, I think we've discussed that to death. And I'm like, no, I don't think we have, because nobody has actually acknowledged that they've heard what I've said. But I really have trouble with that outside of my institution. I admit, I really struggle with that.
Yes, it's very situational where we feel comfortable and where we don't to speak up. And I think that is, either something that comes with time or maybe others in the room making space for that to happen. I'd be interested to hear if either one of you had like a mentor or like a peer that you're like, they're doing something about this correctly and I'd like to emulate them, or they're giving me advice to make this a safer space for everyone.
Dr. Bajaj was mine in Pathways to Leadership. I felt like once I got into that program, one, it took me 3 years of filling out the application to actually send it in. That's how bad my imposter syndrome was. But once I got in the program, I really felt like I was encouraged throughout the process to really stay involved and to go to the next level, to do the training, the trainers. And Peggy Skiles, the same thing. She was equally vocal about getting you involved. So I think there were a lot of people in that generation of ASPS leadership that really had a handle on things, and were sincere about it. Weren't just saying, "Oh, we got to have diversity, so let's let some of the little ladies in." I really felt like it was very inclusive. I've had other people, whisper in my ear and say, please keep applying, even though you haven't gotten the position you're applying for. But I will tell you, I'm at the point in my life where too many pushbacks, I've kind of lost the desire to keep pushing up against a system. But I would say definitely there were people who encouraged me to just keep on keeping.
I would agree with you. I think, my first involvement in ASPS came from Roxanne Guy, encouraging me at a very down time in my life when I was in academics. Lynn Jeffers has been another woman who is always, just when I thought I was hitting the point where I was done with politics, who would encourage me to do something else, whether it would be to start blogging for PRS or doing PSN or EOL, and that would reinvigorate me. But like you, Victoria, it's the same situation. You do a lot and you give a lot. After a certain point, you start to prioritize, and I'm not going to fight the battles the same way anymore. I make my leadership decisions on what I want to do today based on whether it's something that means something to me and whether I get joy out of it. And that's partly why I enjoy Limitless, right? Because I think the whole program is seeking to offer opportunities and fill voids where in situations that I feel like we struggled a little bit because we didn't have all of those resources available to us when we were in the earlier phases of our careers. And if it's helpful to have more resources for the newer generation, I think that'll make a big difference for the future in terms of improving diversity, dealing with bias, and having a successful and diverse profession of plastic surgeons.
I think that's really wonderful. I know, Anu, I have also benefited greatly from working with you and people like Amanda Gosman as well, just really being great examples, and also really advocating for the next generation. So I echo what Victoria said. I think, though, what resonates with me for both of you is that both of you are really walking the walk, talking the talk. I think you all are great examples of diversity and representation. You create opportunities for equity, and you are very inclusive in your participation in the room at a local level as well as at a national level. Are there any last minute topics you all would like to chat about for implicit bias?
I think one of the things that just is constantly surprising to me is the response that you get from people when you start to discuss their implicit bias or their microaggressions or, whatever the topic is. And, I mentioned it before, they're just so shocked because one, they're drawing from their environment where their behavior has been reinforced and encouraged in some instances. And yet they don't view themselves as being narrow-minded or not inclusive or judgmental, yet it's there, So I think as chair of the peer review, we struggle to make peer review not a punitive process because we want people to be introspective, to look at their way they practice medicine and to try to make it better every single day and not just rely on, well, that's the way I've always done it and I have pretty good outcomes. And I think the same is true with the whole study of diversity and in particular implicit bias, is trying to figure out how do you have that conversation more universally without just really slapping them in the face. And I tell you, the times we've done it, there's often that expression that I just slap them in the face, so I think that's where some of the psychology training needs to come in. That's not my area of expertise. Two of my kids are, but I just think that that's the next phase of how we improve communication and diversity, is to figure out how to bring up these conversations without overly shocking the person who does not see themselves that way.
And also allowing that or encouraging that individual to explore his or her own biases. I find it fascinating, like when you talk about that, I've heard instances, for example, where there are individuals or men who don't consider themselves to be biased, for example, and they feel like they're open-minded and supportive of women and individuals of color or gender identity, but yet when discussing the accomplishments of, for example, a woman in leadership, they take full credit, like with, I sponsored her, I encouraged her, I challenged her to pursue this role. And they don't see how by taking credit for her accomplishments, they're actually taking away from it and putting their own biases at the forefront. But I think those are conversations we have to figure out how to point those biases out even to our allies, because our allies also have biases. And that's what implicit bias is.
Right. Like the whole concept of lean in, the whole concept of raise your hand, speak up. We had that discussion at one of the women's retreats, and we had someone come and talk to us, and he's like, I'm a proud, father of daughters, and I, encourage my daughter to raise her hand and speak up. And I said, well, shouldn't you be helping her do that, not telling her to do it? A good teacher is going to recognize that a kid knows the answer and not wait for that kid to raise their hand. That a lot of the self-help books that are out there are perpetuating the biases, that you just have to speak louder to be heard, and then we're aggressive. I think we need to retrain how society looks at each other.
That is definitely one of the biggest challenges that faces us in terms of people that are not recognizing their implicit biases also still sort of coexisting in our personal space and in our work space. And I think there isn't an easy answer. And ideally, we will teach the next generation to do things better or differently. And I'm hopeful, because I see that a lot with my medical students as well, that some of the things that we would have just tolerated, they immediately call out. And it's something that is in their mind when they talk about evaluations for faculty and for rotations. And so I agree. I hope that society continues to get better and we just do better with time.
And it's a matter of listening and having conversations. And listening is a two-way street. And I think that's an important thing we have to realize.
Well, excellent. So with that, I think we'll close it out this weekend. Thank you so much, Victoria and Anu, for sharing your expertise on the topic of implicit bias with our listeners. You all have both been excellent, thought-provoking guests, and we just really enjoyed our time tonight. Thank you so much.
Thank you for having me.
Thank you.
Thank you for tuning in to another episode of the Limitless Leaders podcast series, brought to you by ASPS, the Aesthetic Society, and the American Hernia Society, with the generous support of Allergan Aesthetics. We hope you enjoyed our conversation today and gained valuable insights and inspiration from our guests. Please check out other episodes of your favorite podcast platform. You can download them directly from ASPS EdNet. Stay tuned for new seasons, exciting new episodes where we will continue to celebrate and empower women leaders in plastic surgery and in general surgery. Thank you.